Hi, I'm Jody Lane with Accelerated Medical Practices, and we host a monthly mastermind just for hormone clinic owners and providers. And it's designed to help you solve the real world challenges you face in your clinic every day. Each session starts with a short teaching topic, just like the one you're about to watch, led by the AMP team. Then we dive into live problem solving with the group. And whether you share, contribute, or just listen, you're going to walk away with something useful to improve or streamline your practice. It's low cost, it's no commitment, and you get the replay if you miss it. And because I really want you to check it out, I'm going to give you your first month absolutely free. Just email me at Jody, Jody, at acceleratedmedicalpractices.com with the word mastermind, and I'll send you the invite. You've got nothing to lose and a whole community to gain. Okay, welcome everybody to the June 2025 Mastermind. Typically, we start off our masterminds with a teaching topic done by one of the AMP consultants, but tonight we have a special guest, one of our mastermind participants, which is Dr. Welch, and he's going to talk about a great topic: should I treat patients who have or had cancer? So, Dr. Welch, I'm going to just keep my mouth shut and let you go and do your thing. We're excited to hear from you.
Perfect. Well, thank you for having me and do this sort of give an opportunity to sort of dig in and review some stuff. So our topic tonight is basically, should I treat patients who have or had cancer? I thought this was a great topic. You could go a lot of directions with this. I'm going to see if also my slides are going to work here. So see that? Michael, I hope I get this right. There we go. By the way, I'm not affiliated or compensated by anyone on this, but y'all do see that slide, correct?
Yes.
Yes.
Perfect. Good. All right. So I decided to go the direction a little bit, which I found in our practice is the most controversial of a woman who walks in is breast cancer. We could talk about prostate cancer, but I sort of went down the breast cancer road. And so I looked at three different kind of examples. There are many. One would be just a 45-year-old PCOS patient that might come in your practice who's diagnosed recently with breast cancer, both unilaterally with lymph node involvement, both with estrogen positive receptors. Maybe you have another one that's a 74-year-old white female, has a history of breast cancer 20 plus years ago, had double mastectomy, had some lymph nodal involvement too, also estrogen and progesterone positive, went through the chemo radiation and was on tamoxifen for approximately 10 years. Or a 65-year-old white female with stage 4, unfortunately, with bone mets, with now no further medical or surgical options. All these patients are different, but their complaints are basically, obviously, low energy, fatigue, loss of vitality, depression, libido. All patients obviously want to feel better, and all patients want better quality of life. So I'm really preaching to the choir when we talk about BHRT. The benefits are there, we know, in the sense of the feel goods, whether they're menopausal, postmenopausal, of getting all the good feels, but also the benefits that are there associated with all the long-term health benefits that for some reasons tend to be ignored, which are big: cardiovascular disease, bone health and osteoporosis, and dementia, particularly Alzheimer's. So can we treat these patients? The answer is yes. Should we treat these patients? Is the direction our question we ask ourselves. In the world of breast cancer, particularly in the topics looking at the hormone positive ones, with cancer, it's a very complex topic. It perks a lot of interest amongst providers. There's immediately, a lot of times, a provider hears this comes up of treating a breast cancer patient or a surviving patient who's in remission, that this is an absolutely no. So it becomes really a lot of different varying perspectives will come into place. The use right now of actually hormones, particularly bioidentical hormones in breast cancer patients or survivors, especially those with hormone positive receptors, are just right now still a subject of ongoing debate and research. And the research, as we know from our trainings with WorldLink, is pretty apparent of the benefits. The recommendations currently state, though, with hormones of any kind, basically, we do not really recommend that for women with breast cancer or even breast cancer survivors. So we have a lot of women that are suffering because their doctor, their provider, it could be or their oncologist, does not believe that hormones are appropriate. Again, most physicians, professional organizations believe the studies involving hormone replacement in any form, including bioidentical hormone replacements, can increase the risk of breast cancer reoccurrence. Which study are we referring to? Well, we have to bring up the WHI as a major study. What we do know now is in JAMA 2020, the follow-up on that study, well, with over 27,000 women, basically showed that the estrogen arm in that study, in that group, showed a protection in women up to 23%, and in the mortality part of that, up to 40%. So this is a complete reversal on what the initial study showed in 2002 when presented to today. So everything the public has been told through the media and the way we were trained traditionally is basically no hormones, but all of a sudden things sort of change. The evidence is also present on benefits of estrogen with Dr. Blooming's book that was presented on Estrogen Matters. I think Dr. Blooming does a good job in presenting his case. Obviously, his wife in the book, who has estrogen, who is basically not going down a good road, and I think he put the effort and the time. Has the reference in that book. Now, I'm not agreeance with him on the thoughts on progesterone and testosterone, but definitely in estrogen makes a great case through the references that he provides that we should be giving women, particularly surviving women, estrogen due to the multiple benefits versus the risk. The medical literature also is strongly supportive of two hormones we have that are completely apoptotic for cancer. And that's going to be testosterone and progesterone. I don't think there's any argument to that, especially amongst the WorldLink providers, that these two hormones are protective and in some cases used for treatment. I didn't really list Dr. Rebecca Glazier in my slides, but her research is there to show treatment with testosterone. So can I treat breast cancer in women? Yes. Should I treat women? Again, it's sort of walking the rope. Unfortunately, research has shown it takes medical providers anywhere from 8 to 15 years to change their clinical practice after new information has been produced on treating certain disease processes. Even the incredible results that we have from the published JAMA article in 2020 still basically has not changed any of the clinical guidelines. Estrogen is still taught as potentially cancer causing. So should I treat? Well, this is sort of where it's very important area of the talk here, basically, is where this is what I do, or sort of where I think is basically everyone should be approached individually. As Neil might say, Rizier would say that basically, everyone's a snowflake. They should be treated that because everybody's different. Everybody's cancer is different. Number two is the education. And I think this is really becoming very important. Using Dr. Blooming's book and handing that to a patient who's had breast cancer, who's concerned, but also is living a life right now that's miserable, they're weight gaining, They don't feel good. They're depressed. But giving them this book is an opportunity for them to educate themselves and then be their advocate also, going to their provider, or if they're still involved with an oncologist, and say, hey, I've got some questions for you, and be very educated in addressing those questions with their oncologist. Number three, if you get into treating breast cancer survivors or even folks so far as with breast cancer, with any hormone management, probably an open and depth discussion with their oncologist or a medical specialist involved in their care, obviously. This could be like Democrats talking to Republicans or vice versa. It's a pretty steep slope we might go down, because most oncologists are probably not going to be on board with any hormones whatsoever. But again, the literature's out there to support, and it's going to continue to grow. It might not be our lifetime, but later on, the importance of using hormones correctly, and in treatment of cancer, as well as treating those cancer survivors. The fourth thing, which I think is extremely important if you decide to go down a road of trying to help a woman in this position, is strong medical attorney-driven consents. And we also recommend here, as well as has been trained, and I think in part 2 of Neil's course, he brings up the idea of your patient writing a letter, a handwritten letter, on the benefits of hormones, and understanding the risk that's involved to be placed in their chart, not a copy, the actual letter, and then giving them that copy. So these are some ideas that we use here in our practice, and when a woman was potentially to come to us and question, can I be treated for hormones? And again, when we sit down, we discuss really in depth the big picture. The big picture is this: we know that, not to belittle breast cancer, but 90% of women with breast cancer will recover. If you're diagnosed with Alzheimer's, there's no treatment really at this stage of the game, where we have that someone's going to recover from Alzheimer's. Cardiovascular disease, 7 times most of those women that have breast cancer are going to die from cardiovascular disease. Many women die from complications of osteoporosis. And again, the feel good part of things is just having better quality of life. So just remember, it's still not standard of care currently to give hormone replacement therapy to anybody with breast cancer or any survivors of breast cancer due to potential recurrence. That's currently the guidelines. It is not recommended until research catches up with the actual clinical guidelines and standards. So the research there, but I don't know, at 5 years since the study was reviewed by JAMA, 5 years now, still not a lot has changed in the general world of medicine on going any direction with hormone management. I think that's it. So I did it 15 minutes. So.
And a beautiful ending. Look at that picture. You guys look so happy.
So.
That was wonderful. Thank you for that.
Well, it was quick, and but I enjoyed the topic. It's sort of diving back into. I really think it's that that the opportunity to go down not a road for us as providers to treat, but better care for our patients who are suffering. I tell women, they come in, 10,000 women with breast cancer, no matter treatment or no, life happens. I think it's 368 out of 10,000 will reoccur. There's a lot of women that don't, and a lot of women live in misery because they're not treated. And they're sort of missing, again, the forest for the trees, because the biggest killer of women is cardiovascular disease. And so, I think looking at the hormones appropriately, um, and going for treatment. You know, when a woman comes in and says, "Well, I'm progesterone positive," and I said, "Well, that's good. What does that mean? It's good." And I said, "Well, high dose progesterone's apoptotic. It's cancer killing." Oh, wow, I didn't know that. And I said, "Well, ask your oncologist." So I think the future's bright. I just think everybody needs to get on board. So there we go.